UK, most surgeries meticulously planned weeks in advance.
Everybody happy?
Okey-dokey.
But every year, 8,000 people suffer injuries so serious
Okay, he's about to arrive.
they need an emergency operation
1, 2, 3.
to save their life.
Can we start?
As soon as these patients come in, the clock is counting down. Can we get some hands? And there's 1,000,001 decisions that you've got to make.
At Addenbrook's Major Trauma Centre in Cambridge,
Hello, Addenbrook's pass your message.
a 100-strong squad of trauma experts and specialist surgeons must bring their different skills together.
It looks a bit like a Formula One pit lane. Everyone has got a job to do.
Sorry, darling, I'm really sorry.
All under the most intense pressure imaginable.
The fiddliest bit of the bloody operation.
Nothing prepares you for the responsibility.
Personally, I think they're heading towards amputation.
Everyone's fearful of making the wrong decision.
My goodness, don't see that every day.
One wouldn't be human if it wasn't shocking. This is someone's life.
It's a horrendous injury.
From resus to the operating table, 20 specialisms combine to save one life.
Hello, Addenbrook speaking. Pass my message.
Got a trauma patient, 51-year-old motorcyclist, male versus the barrier for a partial amputation of the radial ulna.
A motorcyclist on his way home from work has collided with a crash barrier at 70 miles an hour. He has multiple injuries so severe, he's being brought to Addenbrook's Major Trauma Centre.
Can we get some hands?
Partial amputation of radial ulna, an impaled wire to his abdomen.
51-year-old Adrian's life is now in the experts' hands.
All right, sir, you're in the right place, taking good care of you, okay?
Adrian's condition is serious. He is very unstable. He's at a real risk of dying. So we need some blood. We could lose him in the emergency department. Have we got a porter grabbing the first pack one? They're gone. Fabulous.
The 12-strong trauma team must work together fast. They take up position around Adrian. An anaesthetist at his head to check his breathing. An emergency doctor to identify injuries that most threaten Adrian's life. 2 general and 2 orthopedic surgeons to assess if he needs urgent surgery. A physician assistant to insert intravenous lines. 2 nurses on either side of Adrian to give him fluids and monitor his pain. And standing where she can see the room, the trauma team leader, Dr. Mariam Imam.
The first few minutes trying to stabilise a trauma patient is pretty much detective work. Can we get the PA through to get some upper limb access? Finding out clues as to what could be going on and what life-threatening injuries he might have. Can we do our primary survey, please?
He's got laceration here on the chest wall.
Okay. We've also got a wire sticking out of his left abdomen.
He's got definite swelling over the right side of the abdomen.
Okay. And then he's got that potential amputation of the right upper limb.
Yeah.
Circulation-wise, his last blood pressure was 70. Has he got strong radial pulses, please? Can someone confirm?
Adrian's blood pressure is dangerously low. It's a sign that he's losing blood, but they can't see where from. If he loses much more, his heart could stop.
Adrian's lost up to 1/3 of his circulating blood volume. My instant concern is for his chest and his abdomen. He could be bleeding to death from those places and we can't see it.
Have you got an ETA on that blood?
Every second counts in those situations.
An average body has 10 pints of blood. Adrian is given around 4 to put some back into his system. It's pumped through a warmer to heat it to body temperature. Blood that's too cold would send him into hypothermia and kill him.
Hiya, sweetheart. sweetheart, what's your name? Adrian. My name's Mariam. You're in Addenbrooke's Hospital.
The extra blood starts to bring up Adrian's blood
You've got some
pressure.
significant injuries there, okay, sweetheart? What we'll do is we'll give you some pain relief, and we need to get you straight through to the CT scanner. Where is most of your pain at the moment? Your arm. Okay. Okay. That was 10 of morphine that's gone in, and we're going to get some ketamine and fentanyl.
The cocktail of pain relief drugs he's given includes ketamine, which induces short-term memory loss, so he won't remember.
Our CT ready. They're ready? Let's go. Yeah, let's go.
The team urgently need to know if the wire that impaled him when he hit the crush barrier is causing internal bleeding, and he needs emergency surgery. He's taken from resus to CT for a scan.
One of the big unknowns with Adrian is what this wire is doing, poking into his abdomen. We don't know how deep it's gone and what structures it's injured on its way in. It could mean it's gone down into his vital organs, into his lungs or heart. This could be catastrophic. He's going to end up in theatre tonight, isn't he?
Right now, Adrian is the most critically injured patient in Addenbrooke's. The 3-strong radiology team have moved him to the top of their list.
You've come to CT scanning where we're going to take some pictures, all right? I'll explain to you what we're doing as we go along.
We'll go all the way across on 3, please. 1, 2, 3.
Adrian's arm was boxed by the ambulance crew to keep it stable to stop further damage.
It's going to really get caught in the scanner. A bit worried about how it's going to fit. Oh, sorry, darling, I'm really sorry. We're going to pull it a little bit tighter. He's not going to like it. You're doing really, really, really well. You're doing really well. I know I've been very cruel already, but do you think there's any chance this arm would go over your head? If you have any problems, just shout at us, okay? Okay, he's doing really well.
The CT, or computed tomography, taken by the radiographer, is a series of X-rays from different angles that create a detailed cross-section of Adrian's body. It's radiologist Rob Bakewell's job to interpret the images and provide an immediate assessment.
Okay, so ready for the hot report? A hot report is the initial radiological survey while the patient is still on the table, and it's vital. If you scan a patient and wait an hour for the report to come out, you could have missed a major injury. The patient could be bleeding to death and you didn't realise.
So what did we get?
There's no thoracic aortic injury, so it doesn't look to be any intra-abdominal bleeding. So the wire's just in the subcutaneous fat, it doesn't leak into the peritoneal cavity.
The scan shows the wire in Adrian's left side hasn't punctured his peritoneum, the membrane surrounding the vital organs in his abdomen.
So, do we need to image the arm now?
Yes, please.
With internal bleeding ruled out, the priority immediately switches to Adrian's badly injured arm, now the most likely source of his heavy blood loss. It's stopped bleeding, but they need to do an angiogram, a type of X-ray, which will show if his blood vessels are intact.
So this is where there's broken bone and there's air in the soft tissue. Yeah, so this is where it unfortunately doesn't bode well for the patient.
I can see that there's a significant injury. I haven't seen many patients with similar injuries that have gone on to keep their arm.
This poor man.
We now have to focus all our efforts on trying to save that right arm.
Well done.
He needs specialist input and he needs it now.
As Adrian is brought back to resus, orthopaedic surgeon Hassan Fawi, who specialises in broken bones and joints, is urgently called from another car crash patient to assess Adrian's badly damaged arm.
He's not got any significant thoracic or abdominal injuries, actually.
Yeah.
So actually it seems at the moment it's all the right arm that's the main injury.
Okay.
Until now, Adrian's arm has been deliberately untouched since paramedics boxed it at the roadside to prevent further damage to its blood vessels and nerves.
So we need your cooperation for this, okay? So we've got the orthopaedic doctors here, and what we'll need to do is try and unbox that right arm of yours and have a proper look, okay? Now this won't be comfortable, but that's where we need your cooperation, okay? What I will do is try and give you as much pain relief to try and get you through this, okay? And we'll try and go as slow as we can as well, all right? And are you right-handed? Yeah, okay.
Quite a significant injury here. It's forearm open, the bones here. Deep laceration to the arm.
Along with multiple fractures in his hand, Adrian has an extensive open fracture in his forearm, breaking both his radius and ulnar bones.
The question is it extremely mangled to the extent that he would...
Is it salvageable?
Hassan must decide if Adrian's arm can be saved in theatre, or if the injury is too great.
It's quite an interesting CT report, isn't it?
It is indeed, yeah. Personally, I think this might be heading towards amputation.
Amputation is always the last resort. Hassan must consult the on-call plastic surgery team to see if their skills in repairing nerves and blood vessels could help him to reconstruct Adrian's arm.
Ali, hi, it's Hassan. This is a significant injury here, so the question is whether it's salvageable or not. I think we need some shared decision here, whether he's going to have a functional limb after this, whether we go for an amputation or not.
Adrian, Sharon is on the phone. Are you happy for me to speak to Sharon? And let her know how you are? Okay, all right, thank you. He's come off his motorbike. He's here with us, still in the emergency department, okay? The most kind of serious injury is the one of his right arm. So it's really seriously injured. It's in a real bad way. Oh, it's okay. There is a chance he could lose it, yeah. I'm afraid so. If you dwell on the pain and suffering people are having, you might not be able to continue with your job. So I think you definitely have to compartmentalise it so that you can carry on with your job. Yeah, there have been times where I've kind of cried after work, but never during. Yeah.
Addenbrook's Major Trauma Centre treats 700 critically injured patients a year from across 6 counties in the east of England. A third of them are transferred from local emergency departments because they need the specialist trauma surgery.
Addenbrook's Emergency Department, please pass your message.
Hello, I'm just calling to let you know the transfer is about 15 minutes away.
Yeah, come to the ambulance bay and we'll see you there, okay? Yeah, they'll be here in 15 minutes.
A man with a serious bleed on the brain is being brought 51 miles from Colchester Hospital. He needs urgent neurosurgery, which they can't do. With every minute that passes, pressure is growing in his skull. If it's not released soon, he could suffer catastrophic brain damage or even death.
Do you want to put out a trauma call?
Dr. Richard Kendall will be responsible for getting him to theatre as quickly as possible.
And we're going to go in...
Do one.
Okay. I will just contact neurosurgeons.
As team leader, we put out a trauma call.
Oh, hi, Richard Kendall from A&E here. Hello there.
And the call automatically notifies an anaesthetist, general surgeon, an orthopaedic surgeon, and then an intensive care team as well.
Are you thinking imaging or are you thinking theatre?
While one of 4 emergency theatres is prepped, Richard's flash team of 7 on-call trauma specialists, drawn from a pool of 400, make their way to resus, as well as 3 neurosurgeons.
We'll see you shortly.
The preparation is fundamental to the workings of the team.
So let's just quickly whip through this. Notify me, yes.
Making sure that we've got the relevant drugs drawn up and that equipment is ready.
Trolley. Have we got the airway trolley? We need the C-spine immobiliser, please.
What's his name on that form?
Corley. Right, equipment tower. Where are we up to?
Within 5 minutes, Resus is filling with the trauma experts.
The big challenge of working in a flash team like this
Hello.
is that you really don't know the other individuals. You don't know these people's names. You've just been thrown together.
Who have we got here? Anaesthetist. Hi, I'm Richard. Who else have we got?
Neurosurgical range.
And
Ortho range and SA track.
okay, great. And NCCU.
It's really important everyone is briefed, everyone knows what their role is and what they have to do.
So this is a 25-year-old man, allegedly assaulted in the early hours of the morning, taken to Colchester Hospital, had obvious head and facial injuries. So he had a CT head, and that's identified a big subdural.
The priority is absolutely crystal clear. He has to be got onto the operating table as quickly as possible.
12 hours ago, 25-year-old Corley was punched outside a pub and hit his head on the pavement. Since then, he's deteriorated and his condition is now critical. He's been anaesthetised for the journey.
So I think the plan is him getting onto our trolley, quick primary survey, and go to neurotheatres as soon as possible.
The CT scan Corley had at Colchester Hospital revealed an extradural hematoma, a blood clot growing between his skull and the dura, the protective sheath around his brain. The bleeding is causing pressure to build inside his skull. If a section of the skull is not removed to relieve the pressure, the clot could continue to grow and kill him.
OK, guys, who's going to hand over? Thank you.
He was assaulted by a stranger. He got a CT brain, shows extradural hematoma to the left frontal.
With every minute, the risk of brain damage grows. Corley needs to get to the hospital's emergency neurotheatre.
All good to go, Billy, you ready?
Yeah,
Hi, Vito. I'm down in ED with our extradural patient. The bloods have been done. He's going to go to theatre.
It normally takes up to an hour to prep a patient for brain surgery. The 9-strong theatre team have minutes. The anaesthetic team prepares Corley's airway. Scrub nurses position his body and set out the equipment. And 2 neurosurgeons, consultant Angelos Kolias and senior registrar Harry Bulstrode, ready themselves to perform a craniotomy, removing a part of Corley's skull to relieve the pressure on his brain.
The clock is ticking. We say again that time is brain. We just really want to crack on, relieve that pressure ASAP. No faffing about. Do we have the hair clipper? Okay, good. This is really to save his life. Because of the nature of these blood clots, they can expand rapidly and they can then compress the brainstem, the rest of the brain, and the patients can die.
Angelos and Harry are working twice as fast as they would in a planned operation.
Okay, starting.
It's certainly a brutal thing to do, but you're doing a brutal thing in a very carefully planned way.
To access the clot, they must cut through the 7mm thick skull.
What do you think, Harry? You happy?
Yeah, good.
First, they drill a burr hole to create the access they need for the craniotomy.
So we just need to raise the bone flap.
So we just want to go quite frontal, don't we?
The team use a high-speed cutter to remove a flap of bone. Eight minutes into the operation, the pressure on Corley's brain is released.
Just be careful so that it doesn't...
And the clot is exposed.
When the pressure comes off from the clot, the pressure comes off us to an extent.
All right, so we've got the clot there. Suction.
Better out than in.
Indeed. The clot's coming out.
Moving the clot is a bit like cleaning up mess with a hoover, you know, when it really needs doing. Quite satisfying process.
Oh, I like that. It's very minimalist
As Mr. Price say there, you never go to bed wishing you'd done a smaller craniotomy.
But the brain has nicely re-expanded, hasn't it?
Before they can close up the skull, they must check the bleed has stopped.
We need to make sure we're not missing any of the blood clot, which might be hidden, and then focus on making sure that we have controlled on the bleeding point so that the blood clot doesn't form again. So I think we're ready to put the bone back now.
Okay, size this up. There we go, I think that will...
Corley is out of immediate danger.
That looks good. Thank you.
But it's not yet known how the pressure that grew in his skull for 12 hours has affected his brain.
With Corley still in theatre and under anaesthetic, it's very difficult to be sure that he's escaped any brain damage at all. We can only really know that once he wakes up.
How are you doing there? Not too bad. Have had better days, I realise. Okay.
It's 2:30 a.m. While Adrian, who came off his motorcycle at high speed, is in resus, plastic surgeon Ali Arnaout is on his way in from home to check whether Adrian's badly injured arm can be salvaged.
When the phone goes off in the middle of the night, all the adrenaline kicks in, and you have to translate yourself from being completely asleep to being completely alert and awake and being able to make a decision then and there.
Ali must assess how much function Adrian has in his right arm.
Hi, morning. I'm Ali, one of the plastic surgery doctors. Do you know where you are? You're in Addenbrooke's in Cambridge. Just gonna have a look at your arm, okay? That's fine. As plastic surgeons, we look at if there's blood going into his hand. Just gonna have a little feel of your fingers, whether the blood vessels are still working.
If there's no blood supply, the vital tissue in Adrian's hand will die in around an hour.
There is refill. Can you see it?
Yeah.
Looking at Adrian's hand, I am establishing, does he have any sensation? Can you feel me at all? Oh, God. I'm really sorry. And if it's a sensate hand, then it's technically something that we should try and reconstruct. So there's a few obviously different injuries that we need to address.
Yeah.
You've damaged obviously part of your bone and your tendons, but I think there's still the blood supply going into it, which is obviously some good news. What we'll need to do is have a look in theatre and then see exactly what structures are damaged and then repair them individually. Okay? You've got some sensation going into the hands, which might suggest that at least one or two of the nerves are intact. Okay? Which is also good news.
Plastic surgeon Ali must consult with orthopaedic surgeon Hassan, who's already assessed Adrian's arm.
So I've had a look. From our point of view, I think it's for reconstruction. His ulnar artery is intact. I think it'll be worth having a go.
Yeah?
Yeah.
It's decided to schedule emergency surgery for Adrian.
Patient needs to go to theatre as soon as possible, yeah?
Theatre 4 is made ready.
So we've got a 51-year-old gentleman who's come off his motorbike, has got a polytrauma, so multiple injuries, different sites.
Ali briefs the 24-strong theatre team that combines the skills of two surgical specialisms, plastics and orthopaedics. Together, they must try to improve the blood supply to the hand before the tissue dies and Adrian faces amputation.
Ready, steady, slide, stop. He's not far away from being asleep.
Ali's senior colleague, consultant plastic and hand surgeon Alex Reed, will take the lead.
Oh my goodness. Crumbs. Don't see that every day.
Hands are absolutely fundamental to the way in which we interact with our surroundings. Our hands literally allow us to mold the world that we live in. Because the upper limb is so profoundly important We always make every effort to save it.
Alex must establish how well Adrian's hand is being supplied with blood by the forearm's two main arteries, the ulnar and the radial.
I'm going to turn the hand over just to see. And you could feel the pulse, really.
Yeah.
Yeah, you can feel the radial as well, so that's good. Right, are we going to get going?
Give it a little sort of clean.
The force of the impact has caused Adrian's arm and hand to swell. The body's first response to injury, flooding the area with fluid and white blood cells. But this inflammation is putting his already fragile blood vessels under growing pressure.
15 blade, please.
Alex needs to release the pressure, or the flow of blood will be restricted and vital tissue will die.
So we use the existing wounds to release the fascia, this silvery material that helps muscles to glide, among other things. And this is so that the contents have room to expand.
Alex makes cuts to the fascia in Adrian's hand, a membrane surrounding 20 muscles responsible for fine movements.
How do you describe that? Just relax a little bit.
The hands are a bit like a Swiss watch inside. There are many, many moving parts. With these kinds of cases, one tries to make order out of disorder with the options that are available at the time.
These aren't swollen at the moment, but we're doing them in case they do swell. That's it.
Releasing the fascia in the hand and forearm with these cuts gives the tissue the best chance to survive.
That feels a little bit tight down there. I would feel happier if we release that. We've just got to be careful of all these nerves that are coming out. So we can get to it via here, can't we? Look.
It's a painstaking process that takes over an hour.
We're happy with that. The pressure's off now because the tight band's actually on the surface. Yeah, okay. Hassan, can I allow you to come in here? Would that be okay? All over to you. Thank you.
Hassan and a senior colleague take over to stabilise Adrian's fractured radius and ulnar bones.
Arthritic, please.
4 titanium pins are screwed into bone in Adrian's hand and arm, and 2 carbon fibre rods are added to temporarily hold the whole arm together.
Because of the severity of the injury, we need to see what is going to live and what isn't.
It'll be 48 hours before they know how the whole network of blood vessels has responded to the force of the crash. Only then will it be clear if it'll be possible to reconstruct Adrian's hand.
We've done the best we can. Now we just have to wait.
Since the emergency surgery to remove the clot on his brain, Corley has been recovering on the ward.
This is quite funny, actually. This is why I don't like looking in a mirror. I've always had like a really slender face, and they look at me now and I've got a massive like watermelon head. The incident itself, I don't remember. Completely blank for me, but I've spoke to detectives. They saw CCTV of one kid having a bit of a row with another kid, and I was caught amongst it. And I've been hit a few times, and then I've gone to the floor, and all this is the initial impact of me face planting the concrete, basically. And I was just getting so many notifications on my phone. People messaging me from my hometown saying that they heard that I died. And yeah, there was a possibility I could have died. So I'm just thankful I've got people around me that basically saved my life. So it was nice.
Hello, Adam Brooks, pass your message. Head-to-head RTC. Please find concern. She is currently boarded with a caller.
Okay, and what's your ETA?
10 minutes.
Okay, so if you head to the ambulance bay and we'll make a space for you in green recess.
The team team assemble for the woman whose car has crashed at 60 miles an hour.
Right, are we happy we've got everything set up? We've got 2 nurses, so we can get that if we need.
Dr. Sarah Hazelman will take the lead.
This is Sarah. She is a 39-year-old female, been in a road traffic accident. Her seat jolted forward, trapping her right ankle. So she was there for about over an hour for them to take the roof off.
Okay.
Also got pain on her back, so she's been boarded.
All right, so if we can get across, please, if that's okay.
That's okay.
So my main concern is actually there's quite significant injuries. She's been outside, she's been in an accident. She's just come into a room full of strangers. Ready, steady, left. Oh, sorry, Sarah. She just must be very scared. We're happy to start primary survey.
Trapped in the wreckage for nearly 2 hours while the fire brigade cut her out, Sarah has multiple injuries and needs the expertise of several specialties. 2 orthopedic surgeons to assess bone damage, a general surgeon for injuries to her chest and abdomen, an emergency doctor to check her vital signs, and 2 nurses to administer pain relief and fluids. They must work together quickly to find clues of what the high impact has done to her body.
There seems to be some abrasion on the center of the neck. Okay, have you got pain anywhere? I'm not that calm.
It's still a bit tachycardic.
Tachycardic, yeah.
They find abrasions to the neck and back pain that suggest spinal injuries, raised heart rate, which could be due to internal injuries, and a severely crushed right leg. She needs an urgent CT scan to provide answers. But first, Surgeon Hassan wants to assess Sarah's right leg.
Ow.
Sorry, it's a TB fracture.
Fine. Have you got any pulse at all?
He's concerned her leg's blood vessels were damaged when her car seat jolted forward, trapping her for 2 hours. If oxygenated blood isn't reaching her foot, it could die.
Doctor, please.
The Doppler ultrasound device bounces sound waves off blood vessels in Sarah's leg, which change in pitch, depending on how the blood is flowing.
Have you got any pulse at all?
I can feel something faint, but I cannot hear it.
So her right leg is warmer than her left leg. It's going to need scan. Let's go around for CT unless there's anything else anyone wants to do prior to scan.
Sarah is taken for a full body CT scan to establish how serious her injuries are.
Hi Sarah, it's Lauren. I'm going to be doing your scan. If you feel sick at all, just speak to us, okay?
Immediately, radiologist Rob finds a worrying cause of Sarah's back pain.
Yeah, she has broken it. So she does have some cervical spine fractures. There are definitely some fractures there.
She's damaged the disc at the top of her spine in her neck that should hold together 2 vertebrae, and the joint between these 2 bones is fractured.
The worst case scenario could be, is there risk of damage to the spinal cord, which can have life-threatening consequences.
Sarah's leg is also cause for concern.
So there is some vascular injury associated with this tibial fracture. So there's this segment here where there's a fracture where you don't see the artery. So I think there's an occlusion of the right anterior tibial artery.
She's fractured her tibia, the shin bone, and it's pressing against her anterior tibial artery, blocking the blood supply to the front of her lower leg. Although Sarah's broken neck will need urgent surgery to secure it and prevent her from being paralyzed, it's the restricted blood supply to the foot that's most time critical.
Neck injuries can be fatal, but the neck can be stabilized with a collar in time for it to be fixed. However, with her leg, there was major injury to the bone, which was causing a blockage of one of the blood vessels to the foot. That could lead to an amputation of the foot. So that needed to be addressed straight away by the trauma team.
Sarah is taken back to resus immediately, so Hassan can unblock the tibial artery before the tissue in Sarah's leg starts to die.
My leg's hurting again now.
So we're going to put you in a plaster in a minute, but if it feels too painful, let us know and we will stop. All right.
It's not being painful. We've got this. pain relief in a green tube, which is the worst bit.
The quickest way to restore blood flow is to carefully realign the broken bones here in resus.
It's all right, that's it. Well done, well done. It's all right.
Okay, breathe in the stuff. I know it's hurting. Good girl. If you take loads and loads of deep breaths of this, it will make you not notice the pain for a minute, okay? You'll kind of like blur out.
Okay, put the plaster up. Well done, Sarah.
Now this
Thanks,
leg, can I
Kay.
move this leg a
Yes.
bit? There you go.
Just going to check her pulse. Capillary fill now is less than 2 seconds, which is a lot better than it was before. We're happy that it's kinking up nicely. So it's now in a lot better position. That will help a lot with the pain. All the best.
As soon as Sarah's right leg is out of danger, focus switches to her neck, which is being held in place by a brace.
Sarah? Yeah? How are you doing? Yeah, all right. It's Sarah, the consultant here. I just wanted to come and give you an update because I know it's quite scary lying staring at the ceiling. You've definitely broken the bones in your lower leg, but you have got some other injuries.
Okay.
Are you happy if I tell you?
Yeah.
Yeah, so you've broken 2 of the bones in your neck.
God.
The neurosurgeon is here to come and speak to you, so they can update you a little bit more about the neck. I'm sorry, I know that's a lot to take on board.
Sarah now faces a complex and high-risk operation to prevent the broken bones in her neck from moving and permanently damaging her spinal cord.
Do you want us to ring someone for you, Sarah?
My mum.
Your mom. We will inform her.
Adrian, who came off his motorbike at 70 miles per hour, has been in Addenbrook's critical care unit since the operation to improve the blood flow to his badly damaged hand.
I've been at work for, what, 12, 13 hours, and it was the last day of my, before my day off, and yeah, I dozed off. I woke up finding myself actually heading side on to the crash barrier. I remember the ambulance actually trying to come and cut my jacket away. I was saying the pain I was in was unreal. Plus you can actually turn around and actually, you could sense actually that the blood was pumping out of your arm as well.
So we have Adrian.
Adrian must now undergo a second operation to see if the first one worked, and his hand is now receiving enough blood to be reconstructed.
I was told we're hopeful, but you could lose your hand. That's the biggest shock of all. I'm a chef, very passionate, always have been, from the days of working in France. So yeah, I'm constantly working on my hands.
In Theatre 20, the day team of 22 is gathering. Led by senior plastic and hand surgeon Ian Grant, assisted by colleague Phil Johnston and hand specialist Rebecca Lyons.
Okay, this is the second look of a man who came in after a road traffic accident. We will be looking at the vessels in his arm because we simply don't know what it will look like after 2 days of being on the ITU, and then we're going to make a decision about the next event.
The surgery will reveal whether there's enough functioning tissue, nerves and blood vessels in Adrian's hand and forearm to allow it to be reconstructed.
The energy's gone straight through the middle of his hand, so anything in that part could have been damaged, yeah.
To establish if Adrian's hand can be saved, Ian must first determine if the median nerve, which controls thumb movement and gives sensation to the index and middle finger, is intact. He must also examine the ulnar nerve, which gives sensation to the ring and little finger. Then he needs to check the viability of the radial and ulnar arteries, the main vessels that supply the hand with blood. Finally, Ian will inspect the muscle in the hand itself to see if enough of it is alive to make a reconstruction viable. All these must be in working order for Adrian to keep his hand.
These things will add up and tell me whether we can salvage the limb, how we might be able to reconstruct the soft tissue, and what the outcome will be. The decision won't be made by me in isolation, but we should have a decision by the end of today. I think we are good to go. We are good. Okay, 1, 2, 3.
But this one looks white.
The thumb looks
frankly white. This one looks kind of a bit dusky.
And it feels cold.
Yeah.
That feels cold. That's a bit better. I'm not sure.
Yeah.
Looking at Adrian's hand, some of his fingers are pale, but you can't read too much into it because the hand has been wrapped up in dressings. You know, that tends to make the skin very sort of white, and I'll understand it better when we start dissecting his hand. Do you mind if I have a stool?
Ian starts by opening up a narrow tunnel in Adrian's wrist, through which tendons and nerves run into his hand.
So we have just opened the carpal tunnel, and I'm going on to a critical structure here, which is called the median nerve. Some of them are still connected even to the muscles of the forearm, which is encouraging as well. Nerves are really important. The nerves conduct information from the brain down to the hand and from the hand back to the brain. And without that ability, you can't feel anything. You can't move the hand. A nerve, and that is pretty encouraging to this point.
With both the vital median and ulnar nerves intact, Ian must now establish how well blood is flowing into Adrian's hand.
So there's blood reaching this bit of the hand, which is reassuring, from the radial artery which runs along here, but not much from the ulnar, if any, at all.
But even with intact arteries, it's becoming clear some tissue in Adrian's hand has started to die and succumbed to the ancient killer, gangrene.
Right, big scissors. So we're cutting away tissue that we know is going to die to reduce the amount of necrosis, which is death, that then can make the patient ill. So this is stuff that is already lost. We are not throwing away anything that is of value to him. You cannot keep dead tissue. Dead tissue has to go. If you leave it, it will be a focus of infection, and he could get sick, and he could get sick very, very quickly. Yeah, so where do you think? Do you think to there? All the way to there?
I think so, yeah.
Those intrinsics look pretty awful, don't they?
They do, yeah.
You know, and they smell a bit as well.
That tissue's not viable.
Ian can use tissue from elsewhere on Adrian's body to replace what he's cut away. Now he turns his attention to the hand's muscles.
For Adrian's hand to be a winner for reconstruction, we need to know that there are enough muscles to allow the fingers to be manipulated for it to be useful for him. So this is dead muscle.
Yeah.
This is probably a muscle called the first dorsal interosseous, and what it does is it pulls the index finger towards the thumb. So this is really sad that this is going. The small muscles which allow you to flex the individual joints of your finger, they're all dead. And the bones around them are dead, and the soft tissues are dead. Okay, so can I ask you to hold that like that? Yeah? This mushy stuff here, this one's a muscle that flexes like that, so you can make a normal fist, whereas in its absence, the hand drops into that posture. So come what may, he's going to have a hand like that. This is really less optimistic as you get inside between these bones here. You should not be able to enter that space. This is very sobering, because I think we are going to have to make a decision about whether this is really a winner.
Yeah.
Right, my personal opinion at this point in time is that we should not go for reconstructive surgery.
No.
Because I think the whole hand could die.
Yeah.
And we're getting to the point where there is nothing of any great value in this hand.
We have taken out all his intrinsic function.
Yeah, so I've gone from being cautiously optimistic to being
pessimistic.
To being a bit pessimistic. Can we have a chat a second?
The surgeons have a difficult decision to make. Everyone needs to be in agreement.
So, almost all of the extensor musculature is pretty much dead. When you get in the hand, almost all the interossei are dead. So, I think we could end up with an amputation.
Yeah.
Yeah. It's a horrendous injury.
Yeah.
A situation where you can't salvage a limb is pretty devastating. And you do have to have a period where you are either on your own or in a different place. But it's not you, it's them and it's their family and their life experience. Everything he does is going to be put into the context of this moment.
The amputation will happen in a week, once the team have been able to speak with Adrian and prepare him. Sarah's crushed leg is now stable, but the head-on car crash jolted her with such force. Her neck has broken in 2 places and is very precarious.
The best way to describe it was like a fairground ride. So one minute I was driving along and then I don't really know what happened. I do amateur dramatics, so I'm ignoring the fact that I should have an audition next Sunday. Don't worry about that, that's out the window. I'll be at Panto by January.
Sarah needs urgent surgery to stabilise her neck to stop it unhinging and damaging the spinal cord.
Hi, my name is Dr. Smith. I'm one of the anesthetic consultants. The surgeons are planning to go through the front of your neck, right away to the back to fix those 2 broken bones there.
Okay, yeah.
It might be a bit painful when you wake up.
Are you ready?
She's transferred from the high dependency unit to Theatre 22.
So she's 39, RTA on Sunday nights. I'm going to clamp the head, take the bone from the right pelvic area, and I need an oscillating saw from orthopedics with a blade that big.
Hello again.
Orthopedic spinal surgeon Doug Hay will be taking on Sarah's high-risk and complex procedure.
You know, the disc isn't absolutely rigid, but the space here is slightly distracted.
Yeah.
And I think if we leave this, this is going to sort of fall off, and ultimately we don't. If it completely unhinges, that's a disaster.
Yes.
If we didn't do anything, there's a good chance that Sarah's fracture would dislocate, fall forward. Then the spinal cord that runs in the middle of all the bones will be damaged, maybe permanently, with loss of use of her arms, legs, and her bowel and bladder function.
Sarah has damaged a disc and fractured the facet joint between 2 vertebrae in her cervical spine. Doug must replace the disc, but he can't access it from the back as the spinal cord is in the way. So instead he must enter through Sarah's neck, navigating around the carotid artery, which carries blood to the brain, the windpipe, and fragile esophagus. Once Doug has removed the damaged disc, he'll use a small piece of bone taken from the pelvis to fill the gap. Finally, a metal plate will be screwed into the vertebra above and below it to stabilize the fractures.
So I would do it sort of from there to almost crossing the midline. Okay, Magna, can we start? Thanks.
The operation will need 11 people, including 2 orthopedic surgeons led by Doug, 2 anaesthetists, 3 scrub nurses, and a radiographer to take x-rays during the procedure.
Dry swab, please.
Doug will access the damaged disc through the neck, but to reach it, he needs to navigate a risky route.
It's good. Yeah, it's good, I think. Keep going through that. Yeah, so just brush it. And I think you're through it. It's a procedure you shouldn't drop your guard on because there is a narrow corridor of safety to the front of the spine and either side are structures that don't react well to injury. The first is the carotid artery.
This major vessel is the main blood supply to Sarah's brain, carrying a litre of blood a minute.
If you did damage that, I think the ceiling would go red. So it's chip, chip, chip. Don't go for a big slide anyway, because it can bleed significantly.
Still actually, but... Okay, so that's clearly carotid there.
Right, so we're in the right sort of ballpark now. On the other side of the corridor, you have the windpipe, and the real structure that, as surgeons, we really don't want to injure is the esophagus, which is the gullet. Where's the esophagus? It's fragile, so we don't want to hit that. You have to treat it very gently, including how you put the retractors in. Before you cut anything, just show me where the esophagus is.
Damage to the esophagus can result in an infection in the chest area called mediastinitis, which has a very high mortality rate of up to 50%.
What I don't want to do is put anything sharp down here until we know where we are. So just use your finger. To the layperson, it might look rather crude, but actually using your index finger is probably the safest tool that you've got. Can you feel the spine? Okay, let's just... Okay, so we know where we are now. I'm not sure we need to go too much further down it. When we've negotiated through the safe corridor when we arrive where we want to be, which is at the front of the spine, yeah, it is a relief. Okay, can you call X-ray, please?
To ensure they remove the correct disc, they insert a marker and take an X-ray.
1, 2, 3, 4, 5, 6. Yeah, that is the one. Great. We're making good progress.
Doug is now ready to remove the 1 centimetre wide damaged disc that sits next to the spinal cord.
Yeah, that disc is definitely disrupted. Right, let's get the scope in. Spinal surgery can be very microscopic. You're talking about fractions of a millimetre. Could I have a 3mm Carrison, please? We commonly use a high-speed burr, which may sound very unsafe, but it's a very precise instrument. But you need to be mindful that 1 to 2 millimetres beyond that is the spinal cord.
Damage this high up on the spinal cord would be so catastrophic, Sarah would lose all movement in her arms and legs.
Go a little bit further here. I think that's probably enough. Yeah. You know, so this is the back of the disc.
Okay.
We're going to keep that because it'll stop the graft migrating.
Yes, definitely.
Once you've got the disc out, it's like climbing a mountain. You've got to the summit, but actually more people die on the way down. It's not a place to drop your guard. Just trying to get an idea of the size of graft. I was thinking, yes, 5 to 6 millimetre. Okay, that's the one, 5 millimetres, right. Okay, I need a stool now.
To secure Sarah's spine, Doug must replace the missing disc with a section of pelvic bone. Removing it won't affect her.
So, knife, please.
To access it, he makes a 5 centimetre incision.
Okay. So if you put your finger in there, you can sort of feel the board. So, right, saw, please. Oh yeah, nice.
Using an oscillating saw, he must cut the bone to exactly the same size as the gap left between the 2 vertebrae.
Just bring that like that, so that's better. Okay, I need the smallest ossitone, please, and a hammer. Right. Use it. So, there you go. Right, it's just like a bar of soap now. Just got to be a bit careful, otherwise it's ending up on the floor. Just need to take that off. That's pretty good, actually. I reckon that'll do us. Yes. Right, so we're now going to stick that in the disc that we've just removed, and then we're going to put a plate on. We reckon that way. Reckon that way? I reckon that way.
Oh, normally look like a straight
Look at that. Right. So I just need to tap that. Hammer, please.
It's not just falling in, is it?
Yeah, I think it'll be fine. I think that's pretty solid. That's got it. Right. So, plate time.
Finally, a metal plate is screwed on top of the repair to make it secure.
Yeah, that's definitely going in. Let's keep going.
The bottom screw.
Yeah, it looks fine. It's very satisfying to know that with our interventions we've avoided a catastrophe. But the real measure of success is when Sarah wakes up and she can move everything and she goes back to normal life. Right, excellent. We're out of here. Okay, thank you very much.
Sarah will need at least 2 more weeks in hospital. But after rehab, she's expected to make a good recovery. Two months after her car crash, Sarah is back doing what she loves.
When they said my neck was broken, it's quite a frightening thing. I think I probably look at life differently now. If there's something I want to do, I'm going to get out there and do it. I'm just really grateful that I'm still here.
Can you do the one-handed egg cracking technique?
12 days after his motorbike accident, Adrian's hand and forearm were amputated.
I've named my stump Old Stumpy. It certainly makes it a lot easier coping with what is there, really.
During his 8-week stay in hospital, the occupational health team have been teaching Adrian to cook using just his left hand.
The first session actually in the kitchen was, right, okay, let's get on with it.
This looks lovely, Adrian. Looks really good.
I'd like to think that the future actually will look bright. I'm certainly determined to ensure that it is. Almost done with military precision.
I like being part of the journey that patients take. From the moment their life changes pretty dramatically and pretty abruptly, then being somebody who can help them.
Steve.
And I see their struggle and their heroism, and that's a privilege. It's a good thing to do. If you are sick, if you are injured, we will take care of you.